Defibrillation. Basically, what defibrillation is a situation where the heart is not working in a normal fashion, i.e. the lower chambers, the ventricles, are not contracting and pumping blood. Defibrillation gives an electric shock which re-coordinates the electrical activity in the heart and allows the heart to resume back into a normal rhythm. So the reasons we would shock patients: cardiac arrest rhythms, there are two types. One is ventricular fibrillation, or VF. The other one is ventricular tachycardia, but pulseless, because you can be alive in VT and you can be in cardiac arrest in VT. So VF is the rhythm on the left. You have random, disorganized electrical chaos, which appears on the ECG as this weird looking shapes. You can have coarse VF, and the amplitude is very big. You can have medium VF, where the amplitude shrinks a bit, and then fine VF, and sometimes fine VF gets mistaken for asystole, but in essence VF is VF. VT that is pulseless, the rhythm appears in a regular format, but the QRS is very broad. How the AED, an automatic external defibrillator, knows to shock VT that is pulseless, it doesn't actually feel a pulse. It looks at the rate, so how fast the rhythm is, and it looks at the morphology, or the shape, or the appearance of it. And if the rate and morphology are compatible with defibrillation, a shock will be advised. The concern for people is that in an AED, if it fails to detect pulseless VT, it won't give a shock, which is true in some rhythms. However, pulseless VT will rapidly degenerate into VF, and then a shock will be advised. Defibrillation is the cure, and defibrillation is the most important thing for shockable cardiac arrests. The study by Richard Cummins in 1989 illustrates how your survival rate drops, and the survival rate falls by 7 to 10% per minute, and that's with CPR. So the key thing is, as soon as the defib arrives, to get the pads on and see if a shock is advised. Currently, no pun intended, we have two types of defibrillators in ESHT. We have the Intrepid defib, these are the new grey defibs, they've replaced the MRXs, and we have an FRX, which is a true AED. An AED is an automatic external defibrillator. Now the Intrepid defibs, the grey ones that you see on the screen on the left, they can provide both manual defib and AED mode. To manually defibrillate, you need to understand the rhythms, select the appropriate energy, which for most adult cardiac arrests will start at 150 joules, push the charge button, and then push the shock button. But if you're using AED mode on the Intrepid, you turn the dial round to the red AED marking, and then basically you follow the instructions. The FRX, which is solely an AED, you cannot do anything other than defibrillate based upon the guidance, is literally that. It is just an AED. So the Intrepid, you can manually defibrillate and AED. The FRX is just an AED. The pads that are attached to the defibs come in a foil packet. Once you open the foil packet, you then follow the instructions from the machine and attach the pads to the patient's bare chest using the diagram on the screen. The pads are interchangeable, so you can put one pad just below the right clavicle and the other pad slightly anterior to the mid-axillary line. Those pads can be swapped round. However, if you follow the instructions, you shouldn't go too far wrong. All that happens if you put the pads in the, in inverted commas, wrong place, there isn't a wrong place, but if they are in the position not listed on the pads, all that happens is the ECG just gets inverted, but the machine will recognise the rhythm and give a shock advised if it's indicated. So the normal things, pads can be used up to 25 shocks, which is approximately 50 minutes worth of resuscitation. If the patient has severely hairy chest, then you will need to shave only the pad position, don't need to shave the whole chest. And if the chest is very sweaty or they are wet, then you do need to again shave, dry the chest where the pads go. If you're going to manually defibrillate, you can apply the pads in an anterior-posterior pad placement, but in AED mode we'd recommend that you use it in the anterolateral position that you see on the screen. So in terms of using the defib safety, before you push the shock button, you should be performing a manual sweep of the area to make sure that everybody is clear, including yourself, that you have no direct or indirect contact with the patient. And what we mean by that is that you're not leaning against a bed or a couch or a trolley that the patient is on, that you're not hanging onto a drip stand or a bag of fluid or a urinary catheter or a chest drain. Anything that's connected to the patient, don't be touching. If you are using oxygen, we want you to remove the oxygen approximately 1 meter from the zone of defibrillation. When you put the pads on the patient's chest, don't put them over anything that might cause arcing. The concern is that if you put pads on things such as piercings, jewellery, stuff like that, when you give the shock, because the pad is over a metal implement, you may get arcing, and arcing is basically a naked flame, which is why we need you to remove the oxygen, because obviously if you have a naked flame and free-flowing oxygen, then you may get an explosion. If the patient is wet, then you need to dry them, as we've indicated. Bodily fluids, it's fairly self-explanatory, but don't be in either water or bodily fluids when you give the shock, because very basically you may be part of the circuit. People are always anxious, will it kill me? It might do, it may just give you a small shock, but the important thing is your safety and your team's safety before you actually deliver the shock. If you work in the community, you will see defibs in public places. The sign on the right is the current defib sign that you'll see in various locations, and some locations have changed their telephone boxes to defib locations. If you go to a public place defib, some of them have access codes. When you ring 999 or 112, then they will give you the access code to get the defib out of the area. In terms of checking the defib, you don't really need to do very much at all. If you have an FRX, just an AED, you don't need to do anything because it performs a self-test every day. If you have an Intrepid, again, it performs a daily self-test. However, you do need to check it once a week. You can check it more than that if you wish, but you need to check it once a week. So to perform the weekly shock, the black therapy cable, plug it into the test load adapter, which should be cable tied onto the machine. Once those two are together, you push the yellow charge button. When the orange shock button flashes, push the orange shock button, and that is it. You don't need to print anything out. You don't need to do an operational check. The only time you need to do an operational check is if you've dropped the machine. If you've dropped the machine, you should be phoning EME and reporting the machine to it. So there are no operational checks required as part of your normal maintenance of defibs. If you have any questions, then please contact me on the numbers listed on the screen.